Good morning, everyone, and thanks for joining us. This is the part 2 of the basic EP lecture series. We're trying to cover the learning objectives for this morning's lecture is to learn the mechanisms of tachyarrhythmias and to be able to use the surface ECG and intracardiac recording to diagnose the mechanism of arrhythmia, whether it's focal or reentrant. So if we look at the mechanisms or the main 3 mechanisms of tachyarrhythmias, we can categorize them as one of 3, either enhanced automaticity, triggered activity, or re-entry as a mechanisms for the tachycardia. Enhanced automaticity and triggered activity, we can look at them as focal tachycardia. Re-entry is simply an activation wavefront that's going around in a closed path, in a closed circuit. It doesn't have to be a perfect circle, but it has to be closed. And the activation has to be going through the same path every time to be a reentrant circuit, repeating itself every time. So we can look at the mechanism of tachycardia anytime we look at tachycardia as either focal or reentrant. And it's very important to understand the mechanism behind the tachycardia we're dealing with, because once we understand it's focal or reentrant, it helps us decide what medication we can use to be most effective, and for ablation, what approach do we need to use to be successful in ablating and eliminating that tachycardia. This is the closest I can find for you to remember re-entry. Every time you turn on your computer and you're waiting for it to turn on, you see this wheel here. This is the best example of re-entry. It keeps repeating itself. So this is something for you to remember every time you turn on your computer. It's a re-entry. When we look at focal atrial tachycardia, the key thing when you look at the surface ECG to tell whether it is focal or reentrant tachycardia is to look if there is any isoelectric line between P waves. In this case, we have sinus tachycardia, the sinus rate about 110 beats a minute. And this is 2-to-1 AV conduction, P wave with non-conduction here, PQRS, P blocked, PQRS, P blocked, P conducted. So you have 2-to-1 AV conduction. But the key here is you see atrial activity, P wave and P wave, and in between there is no activity whatsoever. So this is typical of focal atrial tachycardia. There are always exceptions to the rule, especially if the tachycardia is very fast. You may not have enough time to have an isoelectric line between atrial activity. But here you have atrial activity, you finish activating the atria, another atrial activity, and in between there is nothing going on. That's typical of focal atrial tachycardia, and we'll come back and look at that again. Just looking at the surface, you know there's focal activity, not reentrant. And this area here in light blue shade, no activity whatsoever. When you have a reentry, there's always something going on. When you have focal, it's like a flashing light. It flashes, then it stops, flashes, then it stops. When we look at the site of origin of focal atrial tachycardias, by probability, 75 to 85% of focal atrial tachycardias originate from the right atrium, which is nice because you can access it faster without having to go across the septum to the left atrium. And most of them come from the crista terminalis. We talked about it when we talked about anatomy, which is the crest or the area that separate the smooth posterior right atrium from the rough pectinate lateral and anterior right atrium. At the top edge of that crista, that's the site of the sinus node. So this crista terminalis is the site of origin for most atrial or focal atrial tachycardias. The left atrium to a lesser degree, and mostly from the areas of the openings or the osses of the pulmonary veins, the base of the appendage, and other areas like the os of the coronary sinus. But most of focal atrial tachycardias originate from the right atrium mostly from the crista terminalis. Now, if we have a focus that's firing inside the atrium, whether the right atrium or the left atrium, how are we going to decide where it is? Well, one way is to put a catheter with multiple electrodes. The most electrodes we have on one catheter is 20. Usually 1, 2 is a distal, 3, 4 go proximal all the way to 19, 20. This is a duodeca catheter, 20 poles. We come from the IVC, turns around in the right atrium, goes into the coronary sinus. Remember, the coronary sinus separates the left atrium from the left ventricle. So it's recording the left atrium electrogram. This portion records the right atrium electrogram. This catheter here is in his position. This catheter is the right ventricle catheter. This is an LAO projection, and this is the ablation catheter. Just to put things in perspective, this is the right atrium, and this is the dotted line to represent the tricuspid annulus, the left atrium with the dotted line to represent the mitral annulus. The coronary sinus would be here. So part of the duodec, the distal part, is in the coronary sinus, recording atrial activity from the left atrium. The proximal poles recording atrial activity from the right atrium. So when you have focal atrial tachycardia, the earliest of these poles would be closest to the focus or the site of origin of the activity. So let's look at this example. We have the duodec, and these are the 20 poles, distal 1, 2, 3, 4, 5, 6, going to the proximal 19, 20. We have atrial tachycardia, and you can see PQRS, P within the T wave, QRS, P within the T wave, and then the QRS to follow there. But look at the atrial activation time. You activate the right atrium here, the proximal poles, the CS, the left atrium, in a fraction of the cycle length of the tachycardia. Activating both atria, and nothing in between. Remember, isoelectric line, no activity in between atrial activation times in case of focal atrial tachycardias. So if you look at this, you say, okay, well, let's look, where is the earliest activation? We find it here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. We think, okay, 13, 14 is the earliest, and it is in the right atrium. So just by looking at this, we know the focus must be in the right atrium, not in the left atrium. Is it closer to 13, 14? Yeah, but we don't know how close or how far. But it's not enough to find the closest you can record with this duodec. You have to be earlier than the surface P wave. So you need to find, this is the same atrial tachycardia. You can see here QRS, T wave, and P wave within the T wave. P wave within the T wave. The same thing here. So you really can't tell exactly where the P wave starts. So you need to find the P wave that's dissociated from the T wave. In this case, it's occurring spontaneously, but we have some pacing maneuvers that will strip the P wave from the T wave, so we know exactly when it starts. And we can delineate in this beat, the P wave starts way earlier than 13, 14 that we thought it was the earliest. So 13, 14 cannot be the site of origin of the impulse, because that impulse caused the P wave way before that. But we know it's in the right atrium, so we keep looking in the right atrium until we find a spot. This is the ablation catheter, a spot with fractionation, and you can see the electrogram here fractionated, and 42 milliseconds earlier than the surface P wave. I could not find any better spot in that right atrium. That's the spot we thought it was causing this P wave, and it's earlier than anything else. We burned here, and that terminated this tachycardia. And this is the patient. We had a grade 3D here. This is the head of the patient. This is the SVC, the IVC, the right atrium. This is the lateral right atrium. This is the edge of the tricuspid annulus. On this side here, the left atrium with the pulmonary veins. and this area corresponded to the mid to upper crista terminalis where we terminated it. The software we have for the 3D mapping gives us the earliest, a red color. As you go farther and later, it gives you yellow, green, blue, purple, and dark blue and purple, the later you go. So when we see the propagation map of that focus, we can see how the activation starts in this spot and spread in all direction in the right atrium and across to the left atrium. And that focal ablation here in this spot was able to terminate the tachycardia. So just looking at this example, we can define some of the characteristics for the focal atrial tachycardia. Activation spreads in all directions from a focal site. Duration of activation is a fraction of the tachycardia cycle length, as we said. In between activation, we have areas of electrical silence. If we give adenosine, it tends to terminate the tachycardia if given in sufficient dose. So focal atrial tachycardia could be adenosine sensitive. And the way to eliminate it by ablation is by focal ablation. If you are on the right spot, one ablation is enough. We usually give additional ablations for assurance, but one focal ablation should be adequate if we are on the spot. And that's one thing I like to highlight. Since in focal atrial tachycardia, we need to be so accurate defining that spot, you have to be within a few millimeters from the exact site of origin. And it makes a big difference if you think it's a focal atrial tachycardia or reentrant. In focal, you have to be on that spot exactly to be successful. In reentrant, we'll find out that we can go different ways and still get success. How about in focal ventricular tachycardia or PVCs? This is the right atrium, the right ventricle, the pulmonic valve, and the outflow tract of the right ventricle. The outflow tract of the left ventricle is here. These are the sites of origin of most of the focal ventricular ectopies or ventricular tachycardia. And usually when we see Holter monitor with unifocal frequent PVCs and short bursts of monomorphic ventricular tachycardia of the same morphology as the PVC, what we call repetitive monomorphic ventricular tachycardia, think focal mechanism. Think ventricular outflow tract origin of that focus. How do we find that focus? Same thing. We decide first, based on the surface ECG, whether it's coming from the right ventricle outflow tract or left ventricle outflow tract, and go to that area and try to find the earliest site of activation that has to be earlier than the surface PVC. This is sinus. This is 200 speed, millimeter per second, 200 millimeter per second speed, P wave, QRS. This is the PVC. The beginning of the PVC is here. And we found a site that's earlier than the surface QRS, low amplitude fractionated sharp signal, unipolar negative. This is the site of successful ablation. Before we ablate, when we think we are at the right spot, we try to pace from that spot. And this is pacing spike. You may not see it very well, but there's pacing spike here, pacing spike here. These are two paced beats. And this is 12 lead ECG of the paced beats. Compare it to the 12 lead ECG of the PVC itself. Identical. 12 out of 12 match. You pace from the site, you get the exact same morphology. You are very early at the site. These two things gives you a lot of confidence that ablation in that spot should give you success. And in that specific case, this is LAO, RAO. This is the right ventricle catheter, right atrial catheter, right ventricle, right atrial, and our ablation catheter in the right ventricle outflow tract, and the successful site was in the septal area of the right ventricle outflow tract. Another example of focal PVC or ventricular tachycardia. The site was very early. we pace from that side. You see better pacing artifact here. These are 3 paced beats. Compare this to the spontaneous PVC. Once again, identical 12 out of 12 Pacemap, and this site was also successful. Again, you pace map from a site that's very early relative to the surface QRS. This is the PVC. This is where this is the successful site. This is the ablation. Very early, 40 milliseconds earlier than the surface QRS. Fractured, low amplitude, sharp signal with unipolar negative. This site was also successful. And if we are on the successful site and we start ablation, within 2 seconds, all these short runs of VT and ventricular couplets were gone, and the patient had only sinus rhythm, the first ablation. Now let's talk about reentrant tachycardia. Just like the focal tachycardia can happen in the atria or the ventricles, reentrant tachycardia can also happen in the atria or the ventricles. Our lecture this morning will focus on reentrant atrial tachycardias. Whenever you have reentrant atrial tachycardia, that's by definition what we call atrial flutter. And that's a circuit of reentry that could happen in the right atrium or the left atrium, and could be counterclockwise or clockwise. The typical atrial flutter, which we learned about, I think Dr. Hernandez talked about it 3 lectures ago, the typical right atrial flutter uses the isthmus, which is the area between the opening of the IVC and the annulus of the tricuspid valve. We call it cavo-tricuspid isthmus. In this isthmus, the circuit goes around in a counterclockwise or clockwise fashion. Either one, it's cavo-tricuspid isthmus dependent flutter and typical flutter. We just call it clockwise or counterclockwise. How do we decide if it's clockwise or counterclockwise? Once again, you put catheters inside the heart, a duodeck catheter, the proximal poles in the right atrium, the distal in the coronary sinus. So you record the right atrium and the left atrium. And this is the duodeck in the right atrium, proximal poles, and the distal part in the coronary sinus. And this is, in this case, the ablation catheter actually. But let's see how we record atrial flutter and how can we tell by figuring out the timing of recording, whether it's counterclockwise or clockwise. So this is the recording electrodes. If the activation is going from distal to proximal, the distal will be recorded first, then the following 2 poles and the following 2 poles, and so forth. So in this case, we have this recording of the flutter. The surface shows you the sawtooth. Intracardiac recording, you see the distal 1-2 electrodes going to proximal, ending up with 1920. We see 1920 is activated before 1718, before 1516, before 1314. So the direction of activation, 1920 and going this way. And that's a counterclockwise activation. So when you see the recording, we know which is 1-2, which is 1920, and in between, and we simply tell which is first and what comes next. If you're going from 1920 backwards, that's counterclockwise. If you go from 1-2 to 1920, that's clockwise. So in this case, that's counterclockwise isthmus-dependent, cavo-tricuspid isthmus-dependent atrial flutter. And that is the typical 12-lead ECG of that flutter, where you see the sawtooth appearance in the inferior leads, negative flutter waves in inferior leads, positive flutter waves in V1. That's typical of counterclockwise atrial flutter. And I want to highlight the point that always there is an atrial activity going on, a sawtooth with no isoelectric line in between, because the electrical circuit, the activation wavefront, is going around all the time. There is no time where there is no movement of that circuit. So you have no time of silent electrical activity, no time for isoelectric line to be inscribed. looking at the surface ECG, you see the flutter waves, you see atrial activity, no isoelectric line. You can tell with a lot of confidence this is a reentrant tachycardia, not focal. Let's look at this flutter. You see 1, 2 before 3, 4, and 19, 20 is last. So the direction of activation from distal to proximal poles on that duodec. And that is clockwise flutter. So it's simple. You put the catheter inside the atria, you record the activity, and you see that direction if it's clockwise or counterclockwise. And this is the clockwise flutter. It looks like a sawtooth, but not the typical we just saw. The flutter waves in the inferior leads is positive and in V1 negative. So this is the typical for the clockwise, and the one we saw before typical for counterclockwise. Regardless, whether it is counterclockwise flutter or clockwise flutter, both are using the isthmus between the tricuspid annulus and the IVC, and both are treated the same way. This is another 12-lead ECG of typical counterclockwise cavo-tricuspid isthmus right atrial flutter, and you see the flutter waves. Once again, no isoelectric line. But one thing I would like to highlight, if you look at the strip in lead 2 here, you can barely see a QRS, and you think there are no QRSs. But if you look at other leads, there's QRS, definitely QRS here, QRS here, QRS here, but you barely see it there. The flutter wave is almost bigger than the QRS. And this is to highlight that 12 leads recordings are looking at the same vector from different angles. And depending if you're foreshortened for that vector, you may see very little of it. That's why the QRS is very small here versus much better visibility in other precordial leads. Regardless whether it is clockwise or counterclockwise, as long as you define the isthmus as the area necessary for that circuit to go around, all you have to do for ablation is to put one dot of ablation at a time next to each other and create a line, a roadblock. Transmural ablation, creating a scar. Scar does not conduct electricity, so you block that circuit from going around. It no longer can go around in circles. And that's the ablation. The difference between ablation, as you see here, for circuit or for re-entry circuit versus focal. In the focal, you have one spot, like we saw on previous slide, you terminate tachycardia. In re-entry, you tend to need a line, multiple spots. But the advantage of the re-entry, you can put this line here, you can put this line more medial, you can put this line more lateral. No matter where you go, you have a chance of terminating as long as we define that isthmus, that path, that critical path through which the circuit has to go. So you have more leverage and more freedom to go different areas to terminate re-entry circuit. But when it comes to focal, you absolutely have to be very accurate and you have to be on that spot. And that's, again, why it's important to recognize the mechanism of tachycardia. Is it focal or re-entrant? This is pig's heart. This is the tricuspid valve and leaflet and annulus here. And this is the IVC here. And the ablation catheter drawing a line of scar between the tricuspid annulus and the IVC. And this pale area is a dead area that does not conduct electricity, and that's how the circuit stops. Now, the typical flutter uses this isthmus, what we call the cavo-tricuspid isthmus. How about other reentrant that's non-cavo-tricuspid isthmus dependent atrial tachycardia? Remember, all you have to have a circuit is to have anatomic boundaries that force the circuit or the activation wavefront to go certain path. So if we have a scar, like patients who had prior cardiac surgeries, especially if we have a prior congenital heart disease, the point is you cut the atrium and you make a suture there, the suture creates a scar, that scar can become the basis for a re-entry around the scar. And that's something that can happen in real life. And actually, this is a patient. I'll show you the 3D mapping of that patient with the re-entry circuit. But if you have a re-entry circuit around the scar, in order to stop that circuit, you can create a line between the scar itself and pull it all the way to the tricuspid annulus, or between the bottom of that scar to the IVC. You can go any way you want as long as you block that circuit. Excuse me. This is actual patient. This is the SVC. This is the IVC. This is the tricuspid annulus here in the front. This is a lateral view. And this is the scar, a gray, meaning no electrical signal. We record nothing. This is dead tissue, so it's scar. And then during the tachycardia, we record earliest, then later, then later, then latest, and you go around. And earliest meet latest. That's typical of a re-entry. If it was focal, it will spread in all directions. This is typical activation timing for a re-entry around the scar in this patient. And that was the re-entry circuit in this patient. So how did we stop that re-entry circuit? By connecting the bottom of this scar to the IVC with multiple lesions like we see here. That terminated the tachycardia. Now, as you all know, most of the ablations we do are related to atrial fibrillation. And as a result of us creating lines of scars and areas and islands of dead tissue, electrically dead tissue, we create sometimes the substrate for causing atrial flutter. In this case, you can look on the right here. Red is dead. This patient, I isolated the pulmonary veins and most of the posterior wall, but came back with a re-entry circuit using this isthmus that we created by ablation and leaving this narrow isthmus for the signal to go around like this, just like you see how it's going around. And how do we stop that circuit? Well, this is the narrowest area. We go in and put a line here or here, and sometimes just one dot is enough to stop that circuit. This is another patient after ablation for pulmonary vein isolation for atrial fibrillation. We isolated the pulmonary veins and came back with re-entry circuit around the pulmonary veins and using the posterior wall. And this is the activation wavefront using the posterior wall. And the way to stop that circuit, you can put a line anywhere in the posterior wall here or anteriorly. To stay away from the esophagus, we put the line anteriorly. And as we complete that line with this blue dot here, we terminated the re-entry or the flutter. This flutter is in the left atrium, and it's not typical, and it's related to our prior ablation lesions we created. Another case of atrial fibrillation ablation. This was the voltage map in a patient with persistent atrial fibrillation, no prior ablation. It just shows you that most of the pulmonary veins are basically silent, and we have areas of scar already. The atrium is dilated and remodeled and a lot of fibrosis. Nonetheless, this was actually the first voltage map before the ablation. As I ablated and we isolated the pulmonary veins, then we isolated the posterior wall, we changed atrial fibrillation into atrial flutter. And the flutter in that case, the circuit that was left was going around the mitral annulus. We call perimitral or mitral isthmus dependent. And you can see the direction counterclockwise around the mitral annulus. How do we stop this? You can stop it with any line extending from the mitral annulus and any of those scars. You can go anteriorly here between the mitral annulus and the left superior pulmonary vein, mitral annulus, right superior pulmonary vein, or lateral mitral isthmus block between the mitral annulus and the left inferior pulmonary vein. But once we terminated this circuit, the patient converted to sinus rhythm. So atrial flutter is a reentrant atrial tachycardia. It's a macro reentry. It could be cavo-tricuspid isthmus dependent, whether it is counterclockwise, which is the common form, or clockwise. Either one uses the isthmus, and both are ablated with a linear ablation between the tricuspid annulus and the IVC. Or it could be reentry not dependent on the cavo-tricuspid isthmus, and usually related to a scar tissue, either due to prior surgery, like the example I showed you around the incision scar, we call it incisional tachycardia, or prior surgical ablation or catheter ablation, like the other examples I showed you, or scar with prior interventions, regardless, without prior intervention, just like remodeling and fibrosis in the atria due to dilation or cardiomyopathy. Now, let's just summarize. Reentrant atrial tachycardia, or what we call flutter, versus focal atrial tachycardia. Reentrant tachycardia, there's always atrial activity, and you barely see any quiet area without activity if you are recording from both atria. In focal atrial tachycardia, activation time is only a fraction of the tachycardia cycle length, and when you're recording from both atria, you still have time where you have no activity recorded. So this is typical of focal, this is typical of reentrant flutter. To summarize, focal versus reentrant atrial tachycardia. Focal atrial tachycardia, you have one spot that makes the electrical signal, and from that spot it's spread in all directions from that focal site. In reentry, it's a continuous activation following a specific path. In focal, the duration of activation is usually less than the tachycardia cycle length, only a fraction of it. For the reentry, the duration of activation is most of the tachycardia cycle length. Adenosine tends to terminate focal atrial tachycardia if given in high doses. In case of reentry, it only blocks the AV node and allows us to see the flutter waves or the reentrant atrial activity underneath by stripping the QRS and the T waves away. In focal atrial tachycardia, we usually treat with focal ablation, limited area ablation. Reentrant tachycardia, we usually require linear ablation. And that's the end of it. Thank you very much.